Thought Leadership webinar, which is part of our Executive Leadership Series program. My name is Sue Janczak, and I'm the Director of Marketing here at Health Integrated. And today I'm joined by Don Shivers and Paulina Morel, also of our marketing team, to host today's event. So when most of us think of taking an ounce of prevention for our health, typically our minds will go to thoughts of weight loss and smoking cessation, things like that to keep us healthier. While these wellness aspects are absolutely important, at Health Integrated we really take a much broader and a deeper approach to prevention by assessing risk factors in addition to wellness aspects, and then setting goals with members accordingly. To positively impact the trend in cost and quality of care and the quality of life for health plan members and individuals, it's really essential to address an individual as a whole when assessing preventive healthcare measures. And that is to say, tying together their medical needs as well as their behavioral health and social needs in a unified approach to preventing acute illness and to managing or improving existing chronic conditions. So today, we're delighted to introduce Susan Robinson, RN and care coach here at Health Integrated, to lead today's webinar in a discussion of the importance of shifting our collective mindset from reactive healthcare to more proactive and preventive healthcare in order to improve the well-being of individuals as well as the quality of care that they receive. Susan is a registered nurse and a clinical care coach in our Synergy Personal Health Management program. Susan holds a bachelor's degree in nursing from Adelphi University, where she graduated magna cum laude, and she has more than 30 years of nursing experience, is a licensed healthcare risk manager, and has taken graduate training courses in counseling psychology as well. So before we get started, just a couple of housekeeping items for everyone. We are recording today's presentation and will upload both the audio and the PowerPoint to our website by tomorrow. We will also send each of you an email letting you know when this presentation is available online at healthintegrated.com. To facilitate our presentation, all of our attendees have joined us on mute. And of course, we welcome and look forward and appreciate your questions. And we'll allow plenty of time at the end of the presentation to answer them. But please feel free to submit your questions through the chat box function throughout the webinar today at any point in time. We will collect all the questions and then answer them following Susan's presentation. If for some reason time should run out before we're able to get to each of the questions, we will respond to any remaining questions through an individual follow-up email. So with that, I'd like to turn over the presentation to Susan to get us started. Susan, take it away.
Hi, my name's Susan Robinson. I'm a registered nurse and one of Health Integrated's Synergy Care Coaches. And the topic today is an ounce of prevention. And I'm going to focus in particular on risk factors. So there's three things I wanted to accomplish today. Three questions, basically, I'd like to answer for you. The first is, what are risk factors? The second, why are they important? And the third is, how do we at Synergy, with Synergy Coaching, help people to change them? Next slide, please. Thank you. So what is the difference between traditional and preventive approaches to healthcare? I prepared this little contrast here. And I've underlined some of my personal favorites, like the fact that prevention is protective rather than reactive and focuses on people taking personal responsibility for their health rather than developing a dependence on professionals. But there is one problem with prevention, and that is that people think of it as a luxury. So I was working on my presentation earlier this week, and I developed some car problems. And I thought to myself, oh, great, the perfect metaphor. My car mechanic told me that my car needed major surgery, and I think he was just trying to talk my language. The thing is that most of us understand that cars need prevention. You know, if you don't do your oil change, you eventually have engine trouble. If you don't change your timing belt at 120,000 miles, you have big engine trouble. And I can tell you without a doubt after this experience this week with my car that prevention is not a luxury. And we really need to look at our bodies and our health the same way. Next slide, please. So who wins when you do prevention? Everybody, basically. The members win because they feel better. Health plans win because it reduces healthcare costs when people are managing their health better. And I win because, as a coach, I really like to be helpful. Next slide, please. Now, Synergy Care Coaching, the whole model of Synergy is a preventive model. We're out to prevent problems, catch them early, prevent complications. That's really what we're doing on the phone when we're helping people to manage their health better. And that results in a reduction in hospitalizations and a reduction in emergency room visits. Next slide, please. I wanted to define for you what Synergy Care Coaching is. And I would say that it's a series of conversations that build a collaborative partnership with the member for the purpose of improving their health. And there's two phrases in particular there that I'd like you to pay attention to. The first is that it's a conversation. We're talking with people. We're not just monitoring or surveying or giving advice. And because we're just having a conversation with people, they open up to us and tell us very private things. It's surprising that people feel so comfortable. The second phrase is collaborative partnership. We are really working together. It's a collaboration. I have medical knowledge, but the people I'm talking to, they're the experts in their own lives, and I respect that. Next slide, please. What we're doing when we're having those conversations is we're really translating. When I say we, I'm saying the Synergy Care coaches. We're really translating clinical practice guidelines into dialogue. I'm able to guide the members based on evidence-based treatment, but we're just talking. I translate the jargon of medical guidelines into conversation that's relevant to their needs. Next slide, please. And the Synergy coaching model uses 21 disease conditions as selection criteria. And the disease conditions were chosen specifically because they're chronic, they're high cost, and they're responsive to behavioral change, which means that the member can affect the course of the disease with their behavior. And there are aspects of the condition that are within the member's control. Next slide, please. How does Synergy coaching work? I wanted to present this to you from the point of view that I think about when I'm doing coaching, which is the two aspects of dialogue. And there's the content, which is the what we're talking about, and the process, which is the how we conduct the conversation. Next slide, please. I'm very concrete. I like to organize things. This is how I think about coaching. This is what I'm trying to accomplish when I'm talking with someone on the phone. You know, very simple. I'm trying to reduce symptoms, trying to reduce risk factors, and increase self-management and motivation. And in particular today, I wanted to talk about the risk factors. Next slide, please. So risk factor is a term that was coined during the Framingham Heart Study, and I'm going to talk a little bit more about that later. But basically, the Framingham Heart Study was a study that looked at the factors that affect the development of heart disease. And the whole concept of risk factors, though, derived from application of epidemiological methods for determining causes of infectious diseases and nutritional deficiencies. And when you're looking at infectious diseases and nutritional deficiencies, there's a very direct line. You know, if you don't have enough of this vitamin, you get those symptoms. If you have this organism, you get those symptoms. There's a very direct and obvious link. But it's a little different when you apply those principles to chronic diseases. You can't say it's just cause and effect. You can say that there's a significant contributor that seems to affect the outcome in a chronic disease, but there's many contributors. It's multifactorial. There's many variables that affect the development of a chronic disease, and that's why risk factors are correlation. They're called determinants or predictors of disease, but they're not considered a direct cause. Next slide, please. So the reason why we focus on risk factors as part of coaching is basically because we're interested in killing two birds with one stone. A single factor, you know, just affecting a single risk factor can help prevent many body system damages. So we're really looking to get the biggest bang for our buck, so to speak. And also the health benefits of prevention are long-term. They're lasting. Next slide, please. I'm going to go through the 21 disease conditions and kind of group them for you. The first 5 have unknown risk factors, but self-management can reduce the symptoms and prevent the complications of these 5 disease conditions: Crohn's, MS, Parkinson's, rheumatoid arthritis, and ulcerative colitis. So with these conditions, as a coach, I'm really focusing more on self-management than I am on risk factors, because nobody knows what the risk factors are. Next slide, please. And of the remaining 16 conditions, 12 of those correlate strongly with 1 or more of 4 risk factors. Now, when you look at this list of these 12 disease conditions, you can see that these are devastating. They can change people's lives, and they're costly. And basically, these 4 factors are strong contributors to the development of these diseases. Next slide, please. I like this quote from Jimmy Carter: "The awareness that health is dependent on habits that we control makes us the first generation in history that to a large extent determines our own destiny." And I like that quote for a couple of reasons. One is that these risk factors that we're talking about, the ones I just showed you on the last slide, these are habits. They're just behaviors. They can change. We have control of that. And I also like to put it in a historical context. When we're talking about the Framingham Heart Study, when we're talking about applying the concepts, the epidemiological concepts of risk to something like chronic diseases, we're the first generation that has this information, and we really can affect our future, the future of our health. Next slide, please. And we're talking about 4 key risk factors that can reduce the incidence of 12 chronic, costly, debilitating disease conditions. We're just talking about 4 things that we can really focus on and change. And it has a profound impact on so many, avoiding so many problems. Next slide, please. And in this chart, you can also see that there are certain diseases that become risk factors in themselves. So, for instance, coronary artery disease is a major contributor to congestive heart failure. If you have coronary artery disease, if you have a myocardial infarction, a heart attack, you basically kill off part of the heart muscle, and then the heart's not going to function as effectively. It's not going to be able to pump blood as effectively out to supply oxygen to the rest of your body. So, when you don't have enough success with the heart pumping the blood, then you get congestive heart failure, then you get all the problems associated with that. So certain diseases can be risk factors. Next slide, please. And I look at that as a cascade effect. Basically, you start with this risk factor, obesity, and then that's a major contributing factor to hypertension and diabetes. And then hypertension and diabetes are the top 2 reasons that people end up in kidney failure. And kidney failure, you have somebody that ends up in dialysis or needs a transplant. These are devastating life experiences, and they're also extremely costly diseases. Same thing, you have hypertension, diabetes, all starts with this obesity. Somebody tells me, if I'm talking to a member on the phone and they tell me that they have hypertension and diabetes, the first thing I'm going to ask them is, what's your height and weight? Because I know from experience, empirically from working with people, that they're likely obese. And then you end up with somebody that hypertension, diabetes affects circulation. You end up with somebody who has coronary artery disease, kill off part of the heart muscle, damage part of the heart muscle, and you end up with somebody in congestive heart failure. So it's this cascade. It's a series of stages. Each one's triggered by the preceding stage, and it has a cumulative effect, devastating cumulative effect. Next slide, please. And to tell you a little bit more about risk factors, there's the Framingham Heart Study, and I love this study. It's huge, for one thing. It's named Framingham Heart Study because it was a study of over 5,000 residents of Framingham, Massachusetts, and didn't just study that generation, but also the second and third generations. It's from 1948 to 2015. The study hasn't stopped yet. So it's a very, very large study, and it focused on identifying factors influencing the development of cardiovascular and other diseases. And what they ended up with was a prediction of 10-year risk of coronary heart disease based on a handful of factors: age, gender, diabetes, smoking, blood pressure, cholesterol. The way that the predictions work, the way that this model works, is that there are points for each risk factor. It produces a risk score, and then the risk score tells you, what the likelihood is that within 10 years you'll end up with coronary heart disease. Next slide, please. So I did want to give you, as we're going along today, I did want to give you some resources. And these are a few online health risk calculators. The first one is based on the Framingham Heart Study, gives you the risk of a heart attack within 10 years. The next one is from the American Heart Association. You put in blood pressure information, and it tells you information about your likelihood for developing a stroke, a heart attack, or chronic kidney disease. The last one's from the American Diabetes Association. Certainly you can use these to look for yourself and get an idea for yourself where your risks are, and also they're useful when you're working with people, and especially someone that really doesn't think that they have any risks. Next slide, please. This one was interesting to me because it's disease risk by BMI, which is essentially height and weight, and also waist size. And it points out that waist circumference can be a marker for increased risk even in people of normal weight. I think that's fascinating. You might be able to take a look at this quickly as we're on the phone and just see where your own risks are. You can see how it changes for men when their waist size is more than 40 inches, and for women when their waist size is more than 35 inches. I also included a link here of a one-page body mass index table. I think it's really just a convenient way to look up your BMI. Next slide, please. And then after you do all of that and look up your BMI and take a look at some of these risk calculators and identify your own risk or the risk of someone you love, you might want this online weight loss resource. I love this. It's a menu planner, actually. You put in the food that you plan to eat, and it calculates the calories. So this is a tool that you can use to help people to lose weight. Next slide, please. Okay, so I've told you about the 5 conditions that have unknown risk factors and the 12 disease conditions that correlate with the 4 big risk factors: obesity, diet, smoking, and lack of exercise. And then there's, of the 21 disease conditions that we work with in Synergy, there's another 4 conditions. And they have unique risk factors. But in particular, I wanted to focus on depression. And we see a lot of people in coaching that have comorbid depression. They have depression, and they also have a chronic disease condition. And you notice the list here tells you the disease condition, and it also tells you what the risk factors are for that condition. And with depression, 2 significant risk factors for depression are grief and loss and stress. And chronic health problems cause a lot of loss. They impact people in a way that they can lose mobility, they can lose their jobs, income, even recreational activities that they're no longer able to do because of the impact that the disease has on their health. And that itself is an enormous stress. Next slide, please. So depression is a risk factor for disease severity, partly because it can impair self-management. If people are hopeless and they don't see any reason to take care of themselves, they lose interest in self-care because it just takes too much effort. The depression actually interferes with their ability to take good care of themselves. And sometimes it's not so severe that they're not showering or not eating. I mean, those are obvious. Sometimes it's just things like they're not taking their medications properly. When I'm talking to somebody who has a chronic condition and I see that they're depressed and maybe not managing their disease optimally, I'll ask them if they think that the depression is getting in the way. You know, is that part of the reason they're not taking good care of themselves? And then we can address that. Next slide, please. So chronic illness is depressing, and it's a negative cycle. The more depressed they are, the more depressed people are, the less they care for themselves, and then their disease gets worse, and they have even more to be depressed about. Next slide, please. A lot of people that I talk to, they say things like, of course I'm depressed, I'm sick, you know. So I wanted to talk a little bit about the incidence of depression. There, you can see that the National Institutes of Mental Health says that in any given 12-month period, 14.8 million adults in the U.S. have depression. And only 20% of those actually receive minimally adequate care for that depression. Next slide, please. And I wanted to give you an idea of how depression affects people with specific disease conditions, because again, I'm looking at depression as a risk factor, or a comorbid risk factor with these diseases. With people with rheumatoid arthritis, depression actually doubled the mortality risk, and only 20% of those people who had depression and rheumatoid arthritis discussed it with their rheumatologist, and even when they did, they had to bring it up. The doctors never asked them. Next slide, please. With depression and COPD, it's estimated that 10 to 42% of people with COPD have depression, and they're twice as likely, or excuse me, have a twofold increase in the number of days of hospitalization. Thank you. Next slide, please. As far as ulcerative colitis goes, 20 to 50% of individuals with ulcerative colitis don't take their medications as prescribed, and the major factor in the non-adherence is behavioral health. It's also been found that depression and anxiety can actually reduce the effectiveness of the steroids that are used to treat the disease. Next slide, please. Depression and obesity. Depressed people are more likely to be obese, and obese people are more likely to be depressed. And obesity is just a huge problem. We know that in this nation, and the CDC estimates that it costs a whopping $147 billion. That's billion with a B, annually in direct costs. CDC also estimates that health plans spend an extra $1,429 each year per obese enrollee. Next slide, please. So how does coaching help? Here are some results that were validated by a health plan's independent actuarial services. These were members with comorbid depression. They had depression and they also had a chronic illness. And you'll see that there's a significant reduction in the number of hospital admissions, reduction in the average length of stay, reduction in emergency room visits, and the ROI was 3.84. The return on investment for the coaching services was 3.84. Next slide, please. Here are some more results from Health Integrated's coaching services. This was an evaluation of HEDIS measures in people receiving health-integrated coaching. And this was an independent study conducted by a major university. HEDIS, and if anybody's not familiar with that, it's Healthcare Effectiveness Data and Information Sets. That's set by NCQA. And you'll notice in the criteria that they were looking at, like adult preventive services, that's the annual wellness checkup. Well, with coaching, that went up, in this case, in this particular study, the group that they were looking at, that went up to 98.8%. And then when you're looking at things like diabetes care, COPD, and asthma care, these are basically adherence criteria and also preventive exams, so that, again, so that you prevent problems, you catch them early, you prevent complications, and if you can do that, you're going to reduce emergency room visits, you're going to reduce hospitalizations. And these are just phenomenal results. Next slide, please. There's also four things I'd like to mention that I would consider universal risk factors. And those are non-adherence, lack of communication with providers, knowledge deficit, and stress. Next slide, please. And there are some very unique ways that at Health Integrated Coaching that we help with those universal risk factors. For instance, with lack of communication with providers, we do clinical alerts, and what that is it's actually the coach, the very same day we talk with the member, we would type up a letter to the doctor and fax it over to the doctor's office so that they would have the information. You know, we use this when someone's symptoms have increased. We also use it if there's a particular information that the member hasn't shared with the doctor. We do ask the member's consent to allow us to do that, and generally they do allow us. We also can do three-way calls. This is where I, as a coach, would get on the phone with the member and also get the provider on the phone. The three of us would be on the phone together, and either I would be encouraging the member to share with the provider their concern, or I would be expressing that on behalf of the member while they were on the phone and actually modeling for them, teaching them how they should be talking to the provider for themselves to share information and communicate more effectively. MD reviews is another way we do this. This is where one of our doctors at the coaching program would get on the phone with one of the member's providers and discuss the member, discuss the treatment plan, try to understand what the member's concerns are if they haven't shared them with the provider. And a lot of times the providers are really surprised about information that the members just haven't told them. Knowledge deficit, one of the things that we do, we have a nutritionist on staff, and we can do a consultation with her where she would talk with the member. We send the member actually a food journal that they complete and send back to the nutritionist so she can have a better understanding of how they are eating and where their knowledge deficit might be. And then she would make recommendations to them. Excuse me. Another thing that we would do is Medline Plus information that we can send by ground mail or Crane's information. These are just some really good resources for educational materials. And if you haven't used Medline Plus, take a look at it. It's really wonderful and extensive. Next slide, please. When it comes to stress, one of the things that we do is external referrals, and that is basically me asking one of our service coordinators or outreach coordinators for help. Generally, I do this when I'm stumped, when I just, you know, the member needs help with something, usually some sort of psychosocial situation, and I need more resources, community resources, things like employment resources, housing resources, transportation, respite. They're really experts in that and know more about community resources than I do, so I can consult with them. Also, family contacts. I'll ask the member if they'll give me permission to speak one of their family members, and especially I especially do this with the elderly, where I'm speaking with one of their children or a caregiver, to try to problem solve circumstances that are affecting the member. Care coordination is when we meet with the health plan to talk about how best to help the member, what benefits they might have that can help, local resources, community resources that we might not know about. So, and we do the same thing in collaboration with the case managers. For non-adherence, certainly we do education. We also do motivational work to help problem solve any barriers that there are to adherence, and also how basically increase the members' motivation to take better care of themselves. And we can also do clinical alerts with non-adherence, just notifying the doctor that the member's not following through on what was prescribed. But sometimes the members don't tell the doctors. And if you recall, the clinical alert is when we fax the doctor a letter. Next slide, please. I like this quote from Mark Twain. Habit is habit, and not to be flung out the window by any man, but coaxed downstairs one step at a time. And I like it because again, it reminds us that we're just talking about habits here. These risk factors are behaviors. They can change. And I also like it because it reminds us that it takes time to change a habit. It's a gradual process. It's incremental. It doesn't happen overnight. It does have to be coaxed. Next slide, please. I also think that quote is a good transition to talking about the process of coaching. And this is what I'm trying to do. Here's what the process of coaching is all about. It's really increasing darn. Next slide, please. DARN stands for desire, ability, reasons, and need. And that's what motivates people to change their behavior. Having these 4 things present, that's what motivates people to change. Next slide, please. Desire really is the question, do I want to change? Do I want to? The ability is a combination of knowledge and confidence. People have to believe they can change, and they also really need to know what they're changing to. They need to have an understanding of exactly what they should be doing. Reasons are why should I, basically. Why should I change? And need is about urgency. Why should I change now? Now, in coaching, we've been seeing a new trend lately, which I love, and that is members who tell us, I had some problem labs, and my doctor told me he would give me 3 months to do something, to lose weight, to bring my cholesterol down, to change something. And if I can't get it together in 3 months, then he's going to put me on medication. But I have 3 months. Can you help me to improve this? And I'll tell you, this is a coach's dream, because that gives a member a sense of urgency. When the doctor says, you've got 3 months to change, or I'm going to have to start meds to keep you safe, that generates a sense of urgency. And we had a member like this recently that we were working with. She saw her doctor. The labs showed elevated cholesterol and also a high fasting blood sugar. Doctor gave her 3 months to change them. And in that 3 months with coaching, she lost 17 pounds. Her labs came into normal range, and she didn't need to get started on the meds. And I can tell you, she was very proud of herself. She felt really good. Next slide, please. When you're working with people, though, you can't argue for change. You can't try and convince them that they should change. Because if you push, they resist. And the other reason why you can't argue for change is because when people resist, they start telling you all the reasons why they have to do the things the way they're doing them now. And people believe what they say. So if they're spending their time telling you why what they're doing is what they have to do, is the only thing they can do, if they spend their time defending what they're currently doing, they're actually talking themselves into it. On the other hand, if we can talk with them and have a conversation in such a way that we pull pull from them their darn, their desire, their ability, their reasons, their need to change, they still believe what they say. If we can get them talking about those things, they talk themselves into change. And there's natural language markers in that. You know, when I'm working with someone, I'm listening for these markers. If they say things like, well, I want to lose weight, or I'll try, you can hear in that there's a very weak commitment. But if they say to me, I can do that, or this is what I'm going to do, this is what I will do, well, that's a strong commitment. And as a coach, that's what I'm looking to facilitate. I'm looking to help them make that transition by increasing their confidence and their desire and their reasons and their need. I'm looking to increase darn. Next slide, please. And these concepts, this concept of darn and comes from motivational interviewing. Motivational interviewing is based on the work of Prochaska and the stages of change model. And it's really designed to help people resolve ambivalence about behavior change in favor of health. It's helping them resolve that yes, but. Yes, I'd like to lose weight, but. Yes, I'd like to quit smoking, but. It's helping them resolve that ambivalence, that yes, no, in favor of health. And here's just a couple of tips to how to do that. First of all, like I mentioned, you don't want to push people because they'll resist. You don't want to push them especially beyond their readiness to change. If there's no force, there's no resistance. If you can have a conversation where there's no force with them and you're just evoking from them those reasons and that desire to change and their confidence, building their confidence in their ability to change, if you can evoke darn rather than trying to push them into it, that will help them improve their readiness to change. Also, you do want to use powerful questions, how and what questions, to generate self-inquiry and generate their own problem-solving. The people I'm talking to, they are experts in their own lives. So I'm really trying to generate that self-inquiry and their own problem-solving skills. And I can do that with how and what questions. When I was training to be a coach, one of my instructors told me, if you only asked how and what questions, if you didn't do anything else as a coach, you would be a great coach. And I don't know that that's true, that that's the only thing I should be doing, but they are very, very powerful tools to help people explore and generate their own solutions. The next thing is you do want to mind the gap. And by that what I mean is that you want to help people pay attention to the difference between where they are and what they say they want. And generating that discrepancy actually helps people feel uncomfortable with the status quo. And that's a good thing because that will help motivate them to change. You do want to guide the conversation. This is not just chit-chat. This is not just, letting people talk about anything. You want to focus the conversation on the issues of their health and guiding the conversation in such a way that it's actually helping them to move forward, to improve their health. And you do want to do action planning, but you want to stay within reach. You want to help people choose goals that are doable so that they can build a history of success. It may take incremental, small increments, incremental change, but they need to build their confidence, and that takes having some success with change. Next slide, please. So here are some motivational interviewing resources for you. This first one is really great and not always easy to find because it's one of those .net websites. If you go to the library section, there's a bunch of wonderful free articles in there about motivational interviewing. And motivational interviewing is just so practical. It's just such a how-to. It's really useful information. As far as books go, Changing for Good by Prochaska, Norcross, and DiClemente, it's a very readable book. Prochaska starts the book by describing his own motivation for work in this field because his father was an alcoholic and he wanted to help. And we see a lot of people with substance abuse problems that we would normally call in denial. So it's a very readable book and very very good information. As far as tip 35 goes, you can get that for free from the SAMHSA store, Substance Abuse and Mental Health Services Administration, I think is what that stands for. It also is downloadable. If you go to the website and they say they don't have any hard copies in stock, you can just download it. I have at one time, though, ordered as many as 12 of these at one time and didn't pay a dime for them. They didn't even charge me for shipping. It's really a wonderful book. The tools and the assessments that are in it don't just apply to substance abuse. You can really apply them to any health problem. And of course, there's also the motivational interviewing information by Miller and Rolnick. Next slide, please. But one of the keys to having these coaching conversations with members is that they trust us. And that starts with WIIFM, which stands for What's in it for me. Nobody's going to talk to me unless they feel like they're going to get something out of it. So that's really kind of the first thing that has to be answered for them is what are they going to get out of this conversation. And in part, the way that I do that is by putting their agenda first. Whatever's the top of their mind as far as what's the biggest concern with their health, that's what we're going to address first, and that's where I get to prove that I can help. The other thing I like to keep in mind is just that I'm a guest in their life, and that means to me being respectful of people, that including their respect to choose how they want to, how they want to live, what they want to do, even if that means, that they're doing some things that are not the best for them. There's something in motivational interviewing that they call the writing reflex. It's when you see something, that's going to it's going to have a horrible consequence, and you want to correct it. You want to get in there and make it better. And really, as a coach, you have to kind of have some way to manage that response in yourself so that you don't try to push people, because they'll just they won't participate, or they'll resist you, actively resist you. For me, that means just staying neutral, trying to stay neutral and respectful of the fact that it's their choice. Neutral doesn't mean you're detached. I'm actively involved, I'm actively participating, I'm actively listening, and I care about people. But it does mean that I have to respect that it's their choice. Asking permission when I'm talking with people, I'm saying things like, may I offer a suggestion? I'm asking them before I tell them. And if they say no, you can't, then I don't. Would it be okay, or would you be willing to consider those kinds of phrases so that people know that I understand that it's their choice. Also just asking people for information, using those how and what questions rather than just telling them what I think they need to know. Rather than the best way is really to try to evoke from them that self-inquiry. And the other thing is seeking to clarify and understand that what I'm doing when I'm asking those how and what questions in part is clarifying in my own mind their perspective, because what I think and what they think are two different things. I'm amazed sometimes at how different my interpretation was. Once I explore with someone, I discover that my interpretation was just really not what they meant. And that's one of the benefits of asking those questions to clarify your understanding of their point of view. Next slide, please. So there's two commonly accepted methods for change. One is to focus on what's wrong and do less of it, and the other is to focus on what's right and do more of it. And the second one is twice as effective. And that's partly because if you tell people what not to do, they still don't know what they should do. They need replacement behaviors. They need to know what to do, how to do it right. Next slide, please. One of the ways to do that, to focus on what's right and help people do more of it, is through appreciative inquiry. Asking them questions, what are you doing right? Things like what worked in the past. When I'm talking with someone who's trying to lose weight, one of my first questions is, have you ever had any success with weight loss before, and how did you do it? What worked? What helps? Many times when people are speaking, they tend to focus on all the reasons things can't work. And I'm going to refocus them on how can we make it work? What can we do to overcome the obstacles? And also I'm going to help people identify their personal strengths, which you would be surprised that people just don't recognize their own strengths. They don't think they're significant. Things like persistence and courage and curiosity and kindness, caring, those personal strengths can be mobilized on their own behalf. But first they have to recognize them. And I have to tell you, people so rarely hear what they're doing right. I was talking with one man, big, burly, construction kind of guy, and he was depressed and he was working in a job that he hated, and I said to him that I could see that he was just trying to be a good provider for his family. And just saying that to him, the man broke down in tears. People just so rarely hear what they're doing right. They so rarely receive that kind of acknowledgement. And people have to be able to feel, there's a certain amount of feel good about yourself has to happen in order to believe that change is possible. Next slide, please. These are some positive psychology resources. There's one on appreciative inquiry. And this last one about strength-based communication, I really love. You do have to register in order to use the survey, but it is free. Once you register, it is free. It comes out of the work of Martin Seligman. You'll remember him from Learned Helplessness, but he's now working on Learned Optimism. And you'll see on the website, you just go down to the drop-down menu for questionnaires for virtues in action. And when you take the questionnaire, I'm sorry, I can't remember how many questions it is. It doesn't take long, maybe 10 minutes to do. It'll give you your own personal top 5 strengths. And it's really uncannily accurate. And it's useful because it's useful to know that about yourself so that you can exercise those strengths. And it's also useful to think in terms of being able to see and recognize strengths in other people. Next slide, please. So lastly, I wanted to give you some tips for changing risk factor habits. And my favorite from this list is the very last one, which is, if you failed, if you had a relapse, so to speak, how can we learn from that? What did you learn? And how can you apply what you learned to try again, so that you don't, so that you're successful next time? And this is from zenhabits.net. There's a lot of useful information on that website. Next slide, please. So again, what I was trying to accomplish, what I hope I accomplished, was to talk about what risk factors are and why they're important, and how can we help people to change them, in particular focusing on the value of coaching in that effort. Anybody have any questions?
Actually, Susan, thank you so much. That was a terrific presentation. And, it's amazing. We all want to, in some way, shape, or form, when we see somebody that's struggling, we have this innate kind of human nature tendency to want to fix them. So the fact that, you do such a great job as coach remaining neutral and really earning their respect, engaging their readiness,
and frequency? And also, when do you hand off the case to a medical home for ongoing management? For example, how long do you manage a case in general, and when do you bring a closer to the activity?
Okay, there were a lot of parts to that question. I'm not sure if I got all of them. But as far as if I understand correctly, you're asking when do I think that somebody doesn't need coaching anymore? Is that correct?
Pretty much.
Yeah, pretty much it's at that transition point. And how do you do that transition? How do you do the follow-up, and then how do you do the ultimate transition?
Well, there's a few parts to that. If we think that someone needs additional services, other services, we can do care coordination with the health plan, and we can also recommend directly to the member or to a family member, or involve doing a clinical alert or an MD review to see whether or not there's interest in different kinds of services, or if the member needs other kinds of services, different kind of therapies, physical therapy or home care, or other kinds of services like that. With care coordination, we can talk with the health plan and really have a team meeting about what services do people think a particular individual might need or would benefit from. Case management might also get involved. And as far as when do I step out of coaching, we do have graduation criteria. Things like they have to be receiving treatment that's consistent with evidence-based medicine. The member should be adherent to medications and treatment, and also that they should have met at least 75% of their coaching goals for the past 90 days. For me, what that generally means is that if there's a new habit that they have to develop in order to, a health self-care habit, that they've been doing that new behavior consistently for at least 3 months. Basically, that the healthy behavior has become a new habit, that they feel comfortable with it. It's the new normal for them.
So is that about the length of time that it takes for a habit to truly become a habit, about 3 months? Is that what I'm understanding?
It depends. It depends. That's when what I'm talking about is when someone's doing it consistently for 3 months. Like, it's pretty well established if they've been consistent with it. A lot of people that we work with, for example, someone who might be trying to lose weight, they may have a lot of relapses, so to speak, in the course of trying to change how they eat, where they eat well for a little while and then they cheat. And that's not a new habit. They haven't developed a new habit yet. They're just on a diet. And what I'm looking to do is to help people to develop a lifestyle change where they're eating healthy, and they're eating. That's the new normal for them. It's not a diet. It's how they eat. So that's sort of the difference between when they're in that process of they're trying it on versus it's well established.
Okay, great. Thanks.
Thanks, Susan. What is your normal caseload? Can you talk a little bit about that?
Yeah, sure. Actually, I have no idea. And the reason I have no idea is because the way that I look at it is who's on my calendar. I make people appointments every 4 to 6 weeks, and so as many people as I can fit in my calendar, that's how many people I can talk to. There are some people that are very acute, and I talk with them more than every 4 weeks. There are some people, for short periods of time usually, that I'll talk to every week or every 2 weeks until they get through a crisis situation. Most people I talk to every 4 to 6 weeks, and I'm booked every half an hour with another person. I book myself. So if I need to, if I know that someone maybe has over-elaborate speech and talks in over-elaborate detail, I'm going to book myself an hour with that person. Or if I have to use the language line, if I'm talking with someone where I have to have an interpreter, I'm going to book myself more time for that call. But otherwise, I'm booked every half an hour. And And my caseload is as many people as I can talk to in a month.
Do you have an average number of individuals that you work with at any given point in time now? I mean, are there, 20, 30, 50?
I'm guessing it's someplace between 180 and 200 people a month that I'm talking with.
Okay, great. Thank you.
Okay, another question we have, Susan. How do you help someone who already has an advanced disease condition?
I'm going to educate them in disease-specific self-management. I'm going to help them to develop strategies for avoiding triggers. We're going to talk a lot about treatment adherence. I'm going to help them identify supports that they have. And also, I'm always looking, when I'm talking with any member, I'm always looking for what aspects of their disease condition are in their control. So, for example, like if I'm talking with someone who's in chronic pain, and if it's a situation where the chronic pain is just, it's not going to get any better. They've exhausted all the medical treatments, and at this point, medicine is just giving them maintenance treatment, but they're in pain all the time. I'm going to look at things with them like, I know this might sound a little off track, but it's not. Maybe they drink too much caffeine and they're sleeping poorly. They say that they're sleeping poorly because of pain, but maybe they're also drinking a lot of coffee. And if they change that, if they could get a better night's sleep, they would actually have a higher pain tolerance, because when you're sleep deprived, you're more sensitive to the pain. And with people who are in chronic pain, I also talk a lot about mental attitude. And when all else fails, when there's nothing else that you can control, you can still control your attitude about something. And your mental attitude is remarkably powerful. When with chronic pain, for example, I've been doing this now for a while, so I sort of almost have two categories in my mind of people, and the one are the people that allow chronic pain to control their lives, and the other people are the people who are in chronic pain and they refuse to allow it to control their lives. And I'm busy always trying to move column A to column B, in that situation. I'm trying to help people to develop a mental attitude, some strategy. Anybody who's in chronic pain has to, it's something you have to find for yourself. You do it internally. Nobody can give that to you. But there's lots of different approaches. There's things that I can suggest that people can try to find a single thought that helps them to feel better, to get through the day, to cope with the pain in a way that it doesn't control them. And not everybody's ready to hear that, and I do wait for the opportunity to have that conversation with people. When someone has a chronic illness, like chronic pain, I look for what motivates them, what keeps them going, and I help them hold on to that, and I help them discover how they can still enjoy their days. I mean, that's really what I'm looking to do.
Okay, we have about 2 minutes left, so just one last question, Dawn.
Yeah, Susan, how do you help people who don't want help?
Oh, they're actually the most difficult people to work with. In Prochaska's model of change, those people are called pre-contemplative. And there are two kinds of pre-contemplators. There are the people who are unwilling, and there are the people who are unable. For people that are unwilling, these are the people that we would typically call in denial. Like in the addictions treatment, we call them in denial. People that are unwilling, my strategy with them is to raise doubt and about what they're doing, and also to try and keep the door open. I'm waiting. When I'm talking with them, I'm waiting, and I'm also actively looking for a time when they question their own behavior. And usually that happens when there's some change in circumstances, like somebody close to them gets sick, somebody has a heart attack, and all of a sudden they're willing to look at the fact that, they're about 80 pounds overweight. Somebody gets sick, or someone dies, or they suddenly feel vulnerable in some way, or they develop new symptoms, or maybe they get a new grandchild. They want to, be around to see them get married, or they want to be able to lift that grandchild. Something changes. And when that does, I want to be the one they reach out to for help. I want to I'm ready for them. You know, I'm actively listening for that opportunity, and when that change happens, I basically pounce on it. And then there are the people who feel unable, and they're different from the unwilling people. The people who feel unable are people who just don't believe they can change for any number of reasons. Maybe they've tried and failed. I hear that a lot from people who want to lose weight. Maybe there are obstacles, like they've had a hard time affording healthy food, or their spouse brings sweets and potato chips into the house, or their spouse is a smoker and it's a constant trigger for them to smoke. It's a constant temptation. So with people who feel unable, the difference is I'm going to focus them on increasing their confidence and their ability to change. It's a combination of knowledge and increasing their knowledge and increasing their confidence. So I'm going to give education to increase their knowledge, and I'm also going to use strategies to increase their belief that they can change. And that's things like problem-solving barriers, identifying what works, that whole thing with appreciative inquiry, what worked for them in the past, what works for other people, and even what worked but they weren't consistent with it. That's, again, like a lot of things that I see with people who are trying to lose weight. They may do Weight Watchers, and they say, well, you know, it only worked for me when I did it, which is true. It only works for you if you do it. But people have to choose strategies that are sustainable. They have to choose changes that they can do, that are doable for them, and that they can do over a long period of time. So I'm gonna help them focus on personal supports. I'm gonna help them identify community resources that are available to them that might be able to help them. And we talk about all of that. And the other thing is that every time I talk with them, every time we have a call, I'm helping them renew their commitment to change. That's you know, what I do.
Wonderful. Well, we are at time, so thank you so much, Susan, for sharing your insights and your expertise in this area. It was very, very helpful. And thank you to everyone on the phone for joining us today for our first Thought Leadership Series, the webinars for 2013. Again, watch for the email for the presentation to be posted and available to everyone online on our website. And also, please join us again next month when Dr. George Martin, our Vice President of Medical Management here at Health Integrated, is going to discuss ways to reduce avoidable hospital admissions, and that will take place on Wednesday, February 27th. So watch your emails and our website for registration for that as well. With that, this concludes today's webinar. Thank you.